Good morning. I will be talking on unveiling the vitreoretinal interface (OCT) at work. Posterior vitreous detachment is the common phenomenon seen with the aging of eye. It can be complicated by persistent symptomatic vitreomacular adhesion and vitreomacular traction. VMT associated with epiretinal membrane and idiopathic macular holes. Patients may present with metamorphopsia, photopsia, and decreased visual acuity. OCT is helpful in visualization of macular anatomy, quantification of macular hole characteristics, and this facilitates the treatment decision making. Mainly 6 types of vitreomacular interface diseases. Depends on vitreomacular interface relationship. Can be vitreomacular adhesion and vitreomacular traction. VMA is the perifoveal vitreous detachment from the retina but remaining attached within the fovea without retinal abnormalities. And VMT is the retinal abnormalities due to traction from the adhered vitreous within the fovea. And depends on epiretinal proliferation. It can be ERM and LHEP, epiretinal membrane and lamellar hole associated epiretinal proliferation. ERM is the hyperreflective tissue along the retinal surface, and LHEP is the thick and homogeneous layer of material with medium reflectivity, usually accompanied by retinal defects. Next is macular hole. It can be lamellar hole or full thickness macular hole. Lamellar hole is a partial thickness defect in the retinal layers, and full thickness hole is the full thickness defect at the fovea. Then each one in detail. Vitreomacular traction. Normal age-related PVD may be complicated by persistent VMA between the vitreous cortex and the macular area following syneresis. Simple VMA not associated with the structural distortion of the macular architecture, and VMA may exert tractional forces on the macula, causing VMT increase during the ocular saccades during retinal distortion and disruption. Coming to grading of VMT, International Vitreomacular Traction Study Group classification. It can be VMA, VMT, and full thickness macular hole. Vitreomacular adhesion depends on size. It can be focal or broad, isolated or concurrent. And VMT also, it can be focal or broad and isolated or concurrent. And full thickness macular hole can be, depends on the size. It can be small, medium, large, and with or without VMT, and it can be primary or secondary. It's a case of VMT with stable vision. It's an 88-year-old female. Both a status post cataract surgery. Patient had a slight disturbance in vision, and patient presented with 6 vision. And OCT showing a VMT. It was a focal VMT, and patient's vision was stable. We advised regular follow-up in 6 months. It's a case of 60-year-old female with best correct visual acuity of 660 and 24. Patient presented with VMT with a macular hole. Patient underwent right eye vitrectomy with ILM peeling and C3F8 injection. Advised post-op positioning. Following post-operatively at 6 weeks, anatomical closure of hole with a 618 and 10 vision was improved. Next is epiretinal membrane. The proliferation of cellular tissue on the surface of the retina along with the inner limiting membrane appears as a grayish semi-translucent avascular membrane over the ILM on the surface of the retina. It progressively affects the central vision and causes metamorphopsia. OCT is the diagnostic procedure of choice for diagnosing and assessing the extent of epiretinal membrane and its impact on retinal morphology. Coming to stages of ERM, stage 1 is foveal pit is present with well-defined retinal layers. And stage 2 is absence of foveal pit with well-defined retinal layers. And stage 3 is absence of foveal pit with well-defined retinal layers and presence of an ectopic inner foveal layer. Ectopic inner foveal layer is the continuous hyporeflective or hyperreflective band extending from the inner nuclear layer and inner plexiform layer across the foveal region. In this image, the black star indicate the Eiffel layer. And this is a case of ERM stage 4 with a less vision. 64-year-old male with a 624 N12 vision and presented with left eye ERM with the FEP. And patient underwent vitrectomy with membrane peeling and SF6 injection following post-operatively at 8 week. Anatomically restored layers with a visual acuity improvement of 612 N10. Next is lamellar hole associated epiretinal proliferation. It's a thick homogeneous material of medium reflectivity on the epiretinal surface at the margin of lamellar defects, contiguous with middle retinal layers and conforms the retinal layers structures without exerting tractional effects. Originates from the proliferation of Muller cells, can occur independently or concurrently with tractional ERM in lamellar holes. Lamellar holes with LHEP are more likely to have larger tissue defects, disruption of ellipsoid zone, and poorer mean visual acuity. Next is macular hole. It's a full thickness defect in the neurosensory retina at the fovea. Most cases causes idiopathic and can be affects 6 to 8 decade of their life. Coming to the stages. So GIAS classification. Stage 1 is impending hole with 100 to 200 microns with foveolar detachment. Stage 1B is occult hole, 200 to 300 microns with foveolar detachment, clinically seen as a yellow ring. And stage 2 is small full thickness macular hole, less than 400 microns. Stage 3 is full thickness macular hole, more than 400 microns with or without an operculum. Stage 4 is full thickness macular hole with a complete PVD. So, International Vitreomacular Traction Study Group classification, it can be small, medium, or large. Small hole is dimension less than 250 microns and associated with 100% closure rate following vitrectomy. And medium hole is 250 to 400 microns with 95% closure rate following vitrectomy. And larger holes are more than 400 microns dimension with 90 to 95% of closure rate following vitrectomy. Something about the macular hole indices. It's macular hole height, basal diameter, minimal linear diameter, macular hole inner opening. And tractional hole index and macular hole index are the main things we are looking. Tractional hole index is macular hole height divided by the minimum linear diameter, and the macular hole index is macular hole height divided by the basal diameter. Greater MHI and THI are associated with better postoperative functional outcomes, and MHI predicts the external limiting membrane restoration, while minimal linear diameter and basal diameter are predictive of anatomical closure. So, case of macular hole, stage 3, patient present with the BCV of 636 and 18 vision, right eye full thickness macular hole. Patient underwent vitrectomy with ILM peeling and C3F8 injection. Advised strict post-op prone positioning. At 6 weeks, patient had anatomical closure of hole with a improvement of vision of 6, 18 and 12. Next is about lamellar hole. It's a partial thickness defect at the fovea, separation between outer and inner retinal layers with irregular foveal profile and persistent foveal photoreceptor layer. The involvement of photoreceptors at the ellipsoid zone leads to worse visual acuity compared to those with an intact photoreceptor layer. Most patients with lamellar macular hole remain stable over years, and mainly two types of lamellar holes are the degenerative and tractional type. It can be assessed by OCT. The degenerative type is displays a schisis-like configuration, LHEP, often ellipsoid layer disruption, slow chronic degenerative process causing loss of retinal tissue and the disruption of ellipsoid layer. It has the appearance of moustache. The sign is known as moustache sign. And tractional lamellar hole presents with a conventional ERM with an intact ellipsoid layer, and the appearance of top hat, it's known as top hat sign. These are the topics I'm discussing, and thank you.
Thank you, Minnie, for this insightful talk.